I'm the director for the Clinical Innovation Center at UCSF. We're a pretty new department at UCSF, so as you guys know, there are tons of innovation groups at UCSF. Ours is the closest tied to the hospital operations. And the reason why we were formed recently, this is our second operating year. So we're pretty brand new. And the reason why we're here is because we see a lot of digital health solutions basically everywhere. But a lot of times they don't really go back into the hospital side. And so that's the reason why we exist. We work very closely with the medical center in their strategic initiatives. So let's see. So our mission for the CIC is to accelerate innovations to solve the most critical care delivery issues across UCSF. So if the hospital is interested in it, I'm interested in it. And our goal is to tie with the hospital. So if there's a financial incentive within the hospital of cost savings, for example, we actually have an embedded team to work with existing initiatives to support them so that they can get to their target sooner. The way that we work, so I alluded to, we have an embedded work team with service designers and industrial engineers to work with existing initiatives with the hospital. So I think this is my way of, this is a hospital. And then we work, and then we try to reach our target. That's our goal. We also partner with external industries, so entrepreneurs, startups, pharma, academia, if we need expertise from outside the system. So for example, data scientists, we don't want to build that, like there's expertise within the field, so we leverage that expertise. And so if we do succeed in really getting to the target, sometimes we're able to commercialize products and technologies or new care delivery models that would bring it back to the community. So I guess the talk for today, so Nick told us about the pharma industry. So I will try to speak to how we tackle a continuation of care and how this digital solution fits within it. And then the two areas that I think merge well with the pharma industry is translation of evidence-based medicine into care practice. And secondly, the management of high cost and high-risk pharmaceuticals, which UCSF see a lot. This is a diagram that I'm going to explain later. This is a way for us to understand a new care delivery model. It's complex, and it's really hard work. It's not as easy as an app. So translation of evidence-based medicine to care practice. I'm going to use one of our initiatives last year as an example. So do you guys know what delirium is? No. Okay, so it's basically a state of altered mental status for a lot of times seen in the patient care setting. So in the hospital, up to 25% of our patient population experience some type of delirium, which is huge. In the ICU, it could be up to 70 to 90%. So what we have done is that we had a pilot in the neurology units looking into a new way to deliver care for these patient population. And so the pilot looked into a risk prediction tool and also an active delirium monitoring tool that is done every shift. And so with that tool, it also comes with a care delivery pathway. So it involves a whole slew of people. So I want to show you the scope of the complexity of just one clinical pathway. And so this was a pilot done in our neurology units. It showed that it decreased delirium rates and duration, which is great. And now the hospital is like, okay, let's just implement it in the entire hospital. And so since this is something new, we actually had to do this last year. And so the implementation of this took us, involved 15 clinical units, so physical locations. We trained over 1,000 nurses spanning 25 medical specialties, from general surgery to cardiology to liver transplant. So it's a lot of different people. They all have their say in the pathway. And so a lot of times it's really us providing good governance for us to really implement this. Involving like pharmacy, OTPT, PCA, something called patient care assistants, volunteers, family, patients. And we also work very closely with ethics, so our EMR, and we made tons and tons of modifications. So here I just want to illustrate that with any new care model or any digital solutions, sometimes you might start here, right? So the orange is the new care pathway that was introduced. Blue is the existing pathway, so standard of care versus the new way for us to do things. It's very complex, and it actually spans across different professions. So this is a squiggling diagram. A lot of you might have seen it. So pharmacy, PCA, PT, OT, volunteer, social work. And so for us to be able to communicate this and implement this is huge. And sometimes digital solutions only affect a part of this, right? So it might affect, for example, how we use the prediction tool, or how nurses communicate between shifts, like handoffs, for example. And so something that we keep in mind a lot is when we solve a problem, the problem is usually really complex, and a lot of times digital solution only really target a part of the problem. And so with the Delirium initiative, we did explore a couple digital solutions, so I'll highlight those here. So a lot of times, digital solution comes with as we problem solve. And a lot of times in a hospital setting, that's what happened. And so one area that we provided some digital solution is visual and data management. So we're able to come up with new measures that create new meaning for nurses and frontline staff, a way to give them frontline feedback on a regular basis. We also implement a way for Epic to give us a real-time data on operational metrics, which a lot of times we don't have as a system. We also work with Berkeley, so those are the two example projects from Berkeley, where the one on the right and the far top, we looked into how patients could really interact with family members, because a lot of these delirious patients, they really need to understand basically where they are. They need to be oriented to familiar objects, so people from home, pictures of their dogs and loved ones, and so this is their way of basically projecting patients, like family pictures and stuff. The one on the far right, lower right, is our way of testing sensor technology. So this is the one where we use noise, motion, and sensor that's mounted on the patient's bed to monitor interruptions in the patient room. So for delirium, we really want to minimize the amount of disruption, especially at night. Because of HIPAA and all of the things where nurses don't really like to do videotape. So this is what the team in Berkeley came up with. So our goal is to start with some type of prototype, and later on be able to validate, test it, and then disseminate throughout the hospital in this one. One here, this is, I guess, machine learning. So for us, we implemented a risk prediction tool. It took the nurses a long time to learn how to grade a patient correctly. So we're like, okay, this is time consuming for nurses. Why don't we just create a risk prediction tool for identifying these high-risk patients? So that's what we did. So it's still going on right now with a partner at UCSF. The second part that I want to highlight in the hospital is management of high-cost and high-risk pharmaceuticals. So for UCSF, we're a tertiary hospital, but a lot of times we're also a partner hospital where we see the sickest of the patient population, in which they come with maybe pair with not so good reimbursement model. And so in a way, we also are also a research institution. So that means we prescribe emerging therapies, right? So a lot of times patients come in, they get really new emerging therapies that requires patients, families, pharmacists, a lot of different care providers to understand what it means, how much it costs, like what does it mean to the patient and to the health system. So for us to be able to manage the increasing cost and the nuances of pharmaceuticals is really important. So this is the project that's going on right now. We're working with the heme malignancy and the BMT group to understand Medicare lost data, and pharmacy is definitely one of the highest cost category. Because usually when emergent therapies come along, it also comes along with a slew of diagnostics and companion labs and monitoring and things like that. And so for a health system, it's not just the drug that's incurring the cost, it's really the continuum of care of patient. So we want to make sure that these patients are prescribed with the right therapy for the right reason, and then we're able to show that, yes, like they're getting better. So a couple things that I think digital technologies can play a role and that we're investigating is being able to monitor these type of cohorts. So digital management board, being able to provide education for all of these different types of touch points for the patient, and be able to make a decision for the patient safely that takes into account the cost and efficacy, not just the cost of the drug, but the ongoing cost as they're progressing in their illness. The third one is role of robotics in pharmacy compounding. So it takes a lot of times like chemo, highly skilled technicians to make these drugs. And so when infusion centers are all over the place and a lot of times care is being decentralized a lot, we do look into robotics to see whether there are better ways for us to make drugs faster and quicker. So that's another area that we would be interested in. Meaningful heroes, that's always something that we're interested in. The problem is that it's really hard to convince Medicare providers to understand what patients are telling them and that is actionable. So if you could give me something that is both of them are true, then we should talk. So those are something that would be meaningful if we could create a truly meaningful PROs, so patient-reported outcomes. And last but not least, risk prediction tools. So because these patients are really hard to take care of, for us to be able to prescribe the right medications to the right patient population is really important. And for us to know from evidence that it's true. So it's not just really great providers knowing how to prescribe, but not being able to show it in terms of our health system records. So that's a way for us to basically use data to validate what we're doing. Okay, so this is actually one that we just received and just want to announce it with Genentech. So we got a unrestricted genetic scientific grant. And this is one of the ways that we partner with our industry partners. This is a way for us to support up to 3 innovation projects that target solutions to improve patient experience, outcomes in the area of oncology and hemophilia. And our council have selected patient navigation, cancer survivorship, and patient-reported outcomes as some of the categories that we want to work with. So if you know people from UCSF who might be interested in putting in a proposal, feel free to let them know. This is mostly for internal, so these providers will submit a proposal, and then we, as a committee, would select those projects. And hopefully that we could change how we deliver care.